Good morning. I think I was probably a little over-ambitious with a number of slides, so I am going to move smartly through this presentation. Alan Dalton assures me that the Irish speak very quickly in any event, which is not true in the southern part of the United States, but recognizing the needs of the transcriber as well. I understand that the presentation as well as materials that we submitted prior to coming will be on the NDA website. And I did send along our annual report, which has a great deal of data in it about outcomes for people and families. In fact, the Irish will be the first to see it because it hasn't been released in the US. So please go and visit the website in a couple of days and check out that source for more information. Very quickly, I'm going to give you a little introduction, some history, a smattering of the results that we have most recently from 09-10, what use this material has for public managers, what lessons we've learned, next steps, and hopefully questions. Why do we care about outcomes for people, and why do we measure them? In large measure because we've created a movement, not only in the US, but all over, where we've made significant promises to family members and people with disabilities about the benefits of living in the community. Second, ideology alone doesn't make it so. Simply asserting that you're a person-centered caring system does not necessarily result in that outcome. If a tree falls in the forest, does anybody hear it? You have to measure. Also, this is no longer, certainly in my country, a niche program. It's a huge industry with billions of dollars being invested. So the greater the investment, the more the anticipation is for outcomes. Also, if you are about reforming your system, and I gather you very much are, unless you build in measurements of this kind at the beginning, it's very difficult, again, to know whether your lofty aspirations are in fact met. Increasingly, as budgets are cut, this information gives you early warning signs about possible vulnerabilities in your system. So NCI, National Core Indicators, is a multi-state collaboration made up of public managers very interested in understanding the impact of their services. The assumption underlying NCI, again, is if you don't measure it, there's no guarantee that it will happen. And NCI allows public managers of state DD systems, IDDD systems, to measure their performance over time, and also to be able to measure their performance against a national norm. This began in 1997, so we've been at it for some time. It is a collaboration between my organization, the Human Services Research Institute, and the National Association of all the public directors of state DD services nationally. Currently, we have 25 states participating, half, therefore, of all the states, and we just received federal money about a week ago. The Administration on Developmental Disabilities is investing in NCI to ensure, hopefully, that we have the full complement of states within the next 5 years. I think it's probably the largest ongoing database of outcomes for people with intellectual and developmental disabilities, and it is associated with a valid and reliable consumer survey. The history of this, going back to '97, I think public managers in the US recognized that systems were getting extraordinarily complex. The ability to be out among participants in the system to watch what was going on was becoming increasingly more difficult to monitor. At that point, quality measurement had focused primarily on standards and really did not reflect the experience of individuals receiving services. I think there was a strong feeling that quality assurance should, to a large extent, be premised on our values and our vision. We should be measuring the things that we stand for. Voices of people with disabilities, self-advocates, were becoming much more powerful. I think we felt a very strong need to reflect those in this data collection. Technology was making it increasingly easier to aggregate information and analyzing it. And again, continually needing information to measure the potential impact of cutbacks in services. This is a cartoon that shows an operation, and the caption is, "Let's start cutting and see what happens." And of course, without data, that's pretty much what happens. So without NCI, states really can't create benchmarks. Public managers can't measure whether or not their aspirations for reform are met. They're unable to assess whether or not some of our legacy services, as we refer to them in the US, like custodial care, sheltered workshops, are really working, and whether things we're putting in their place are working. Again, without this data, you're unable to really track either negative or positive change, and you're unable to really share with the whole range of stakeholders the results of services. With this kind of data, you can measure strategic goals. You can enhance transparency. I think for many years, information that we collected about the quality of services was sort of a state secret. Nobody really knew about it. And I think that's changing, not as quickly as I would hope it would change, but making information available to everyone. We talked this morning about needing information about choice. People making choices needing information. I think this is an enormously important resource. We've helped states to involve people with disabilities and their families in helping the public managers to interpret the results through quality councils and other mechanisms. And again, it's an important way to communicate values. Quality assurance is really, what you measure is what you're signaling to the system that you care about. This is another cartoon, a little subtle. And it's two gentlemen, one is carrying a briefcase that's circular, and the gentleman is saying, "I see you brought the pie charts." It takes a few minutes, but there you are. When you think about installing such a system, what kind of challenges do you encounter? First, getting agreement on what to measure. My experience in sitting in windowless hotel rooms for many days, thinking about what to measure, is that initially everybody wants to measure everything. And so the hard part is getting it down to those things that are absolutely crucial. How do you make sure that this data gets integrated into your quality assurance systems? Do you have valid and reliable tools to measure these outcomes? What do you do about proxy responses? I mean, that's a whole other field of research. If you're doing personal interviews with people with intellectual disabilities and developmental disabilities, to what extent do you allow next friend, family, carer who has worked with the individual to answer questions? We solve that by basically dividing the survey in half. The first half can only be answered by people with intellectual disabilities, because you really have to be able to read someone's mind to know how they felt about those particular questions. And the second half is made up of questions that a next friend can answer. Reconciliation of disparate state service definitions, again, that probably won't be as much of a problem in Ireland, but as we're trying to compare outcomes of services across states, believe me, there's a lot of difference in how states define what they call a group home, what they call an institution, what they call an employment program. You don't want to make it so complicated that it takes several PhDs and a whole squadron of people to collect the data. You want to keep it as cost efficient as possible. You also need to educate stakeholders about what the information can contribute to their own personal situation. Finally, especially in smaller areas, you worry about survey fatigue. I mean, how many times do you want John to tell his story to the surveyor, right? So you perhaps do it every other year. I mean, Vermont, for instance, where there are, I don't know, 800,000 people, maybe not that many, don't quote me. They do it every couple of years because they don't want to continue to interview the same person. So it's a difficult process, but believe me, it's very rewarding. This is another cartoon that shows a shepherd with a whole gaggle of cats. Can you have a gaggle of cats? I'm not sure. Behind him, and I don't know, do you have the phrase herding cats here? Is that something you say? Good. So the seasoned shepherds are saying the kid is good. So you really need that kid to manage this. These are the states that are involved. There's a fairly decent distribution between the southern, the west coast, the northeast. Those white states there in the middle, there's only 5 people there. So, you know, we really don't worry. And again, don't quote me, okay? NCI provides a way to look at individual characteristics, where people live, what activities they engage in, what sort of experiences they have in the service system, the context of their lives, friends, community, etc., and their health and well-being. The sort of big buckets of consumer outcomes are employment, which is increasingly a priority issue. We're having an enormous big conference in the States in November, totally focused on finding employment for people with ID and DD. Community inclusion, choice and decision making, which we've heard a great deal about today, relationships, and health and safety. We also have family surveys that are mailed to family members that ask questions about information, which came up in a question. How good is the information the family gets about the service system and the nature of their family member's disability? How much choice and control does the family have? Access, community connections. Many families with family members with disabilities experience a significant amount of isolation in their communities. How involved is the family? How satisfied? And are there family outcomes they can point to? We also look at mortality issues around folks with disabilities, staff turnover, abuse, neglect issues, as well as restraints. I mentioned the survey. We require every state that participates to collect a valid and reliable sample of at least 400 individuals. The statisticians tell me that that's the magic number. I'm not a statistician, I just play one on television. But it is random, it is only adults. We're not saying anything about little guys. The family survey goes to families who've got a child at home under 21. Second one goes to families who have an adult family member living at home, which is an increasing phenomenon, believe me. And then to family members who've got somebody living outside the home. Increasingly, this information is becoming an integral part of state quality management systems, and also for reporting requirements to the federal centers for Medicare and Medicaid services. So very quickly, we will sprint through some of these findings, and again, you'll be able to find them on the web at the NDA website. As you would expect, a larger number of people in our sample are male, about 57%. A good spread on level of intellectual disability, about 32% mild, 24% moderate, another 14%, or actually 19% profound, etc. This is race and ethnicity. About 3/4 of the sample is Caucasian, about 20% African American, another maybe 3% Asian, and then you have American Indian and Pacific Islander. Ethnicity, again, only about 7% Latino, although we've just added California, which upped significantly the number of Latinos in the sample. This is where folks in our sample live. Still the biggest number continue to live in their parents' home. And we're seeing that number go up year by year as budgets are squeezed and as, you know, in dividing up the loaves and fishes, they're making smaller amounts of money available to more people to keep the family member living at home, which really does have significant implications for the formal service system, which I won't even go into, which is another whole conversation. Specialized institutional facilities are the big public custodial facilities plus big private custodial facilities. This is just a chart showing the distribution of disabilities. The biggest additional disability is co-occurring mental illness, about 36%, but a significant number of people with seizure disorders, cerebral palsy, the number of people with autism continuing to go up each year in this sample, especially as more and more states begin to take on programs for people with autism. Either excellent, very good, or fairly good overall health. Again, remember, these are people in the service system, right? Where you would hope that they would have decent health. This is around choice. It shows that about 60% of people did not choose where they live. That's not great. Only about 19% did, 22% with the help of someone else. 63% of people didn't choose with whom they live. Even more startling, it seems to me. About 50% were doing a little better on people choosing their jobs. Not so good on people who chose day programs, only about 27%. Only half of people say they're able to choose how to spend whatever money that they have. A much larger number, 60%, can choose their day activities. This basically shows that the further away you get from a custodial facility, the less lonely you are, which is somewhat counterintuitive when you think about all the people that one lives with in a custodial facility, but not the case. Again, typical jobs for people with disabilities: food preparation, building and grounds, retail. We also find that the further away you get from a custodial structured facility, your access to a variety of health services goes down. That's vaccinations, the same thing, cancer screenings. This one is really staggering. This is the number of people on at least one psychotropic med. And many of these people are on more than one med. About 64% in community-based settings are on psychotropic meds. And remember, only 35% of these people had a mental health diagnosis. Again, we did a correlation because we collect BMI, body mass index, and believe it or not, there is a correlation between people who take psychoactive drugs and obesity. What have we learned? We've learned that to be relevant, this information needs to continue to be relevant to public managers, so we've altered the survey at various junctures, most recently to include a whole lot more questions around health status. Don't be too ambitious at the outset, you'll wear everybody out. Continue to try and improve the burden of data collection, and don't use this information for compliance. Don't use it for compliance. Use it for quality improvement. We're working with the CDC, Centers for Disease Control in the US, developing some hopefully good recommendations around health surveillance for people with intellectual disabilities. We're going to have a brand new classy website, so don't go to our website for a couple months, okay? Because it's so last century, I can't even tell you. We're trying to improve the data we collect on abuse and neglect. Again, problems coming up with common definitions. And we hope to expand the number of states. This is what our new website will look like in a couple of months. And finally, are there any questions? All right.